Hi, I'm Dr. Eric Ketcham. I'm an emergency physician. I'm an addiction specialist, and I work primarily for the Presbyterian healthcare system. I work in Espanola Hospital and Santa Fe Medical Center as an addiction specialist and an emergency physician. I work in some other emergency departments around the state, and I've worked with a lot with the state of New Mexico Behavioral Health Services Division through our program called the New Mexico Bridge Project, in which we work with hospitals around the state to help them learn about treating opioid use disorder and understanding buprenorphine as a medication to treat opioid use disorder. So beginning about a year and a half ago here in New Mexico, we really saw fentanyl, and particularly in its newer form, these blue tablets, although there's some now new powder forms. But fentanyl really has become by far the most prominent illicit opioid, and has really, in fact, kind of displaced heroin. Heroin is actually even harder to get now, much than it was before. But fentanyl is very rapidly addictive. It's also very, very deadly, and it's killing a whole lot of people. It's creating just a tremendous problem, and it's also created new challenges. It's harder to initiate treatment for patients who are using a lot of fentanyl, and so we've really had to invest a lot of time, a lot of work into learning new strategies for transitioning patients into treatment, and then of course, having to develop new medication protocols and educating our colleagues. So it is an enormous problem, and we just have to continue to invest a lot more resources to addressing it. So we need to get more and more physicians and nurse practitioners, PAs, etc., to engage in treating, in their offices and in the hospital. But we also need to be able to have the time, invest in the time that it takes to educate folks. In addition to just learning about it, we also need the other services to go along with it. So while medication for addiction treatment, such as buprenorphine or methadone, or for some patients naltrexone, while this is very valuable and it's critical, and it is the life-saving piece, but there's a whole lot of other services that are key to connecting people and getting them into treatment and helping them sustain in treatment, including resources for peer support. And some patients need to do this in a kind of an on-site facility. We really need to begin treating patients who are incarcerated with opioid use disorder. We need to begin treatment there, so when they leave incarceration, they can stay in treatment, have a much less likelihood of continuing to use, continuing to commit crime. We need to be getting more of our hospitals comfortable with initiating treatment while patients are in the emergency department, while they're on the inpatient units, and as well as being able to connect people to clinics. We need more clinics providing these services. But there's a cost to this, and we need to invest in it. But the return on this investment is enormous, and every study that's ever been done shows the tremendous return on investment, the reduction in crime, the reduction in healthcare costs, the reduction in mortality, the lives saved, the people who get their lives back, the improvement in function and employment, and the welfare of children, and the number of people who can remain parents and be able to take care of their children, basically meet their responsibilities, pay their child support. I mean, all those things improve when we get people into treatment. So two specific requests that I would have outside of just funding access to treatment and environments and in many different settings. The two places that are really lacking, where there's a tremendous challenge, is one, correctional facilities. So if we could initiate treatment while people are incarcerated, whether that's in the jail, whether it's in prison, and then connect patients to treatment so they make sure they leave with medication in hand and a clinic they're going to be able to follow up with, this would tremendously save lives and reduce crime, morbidity, mortality, healthcare costs, etc. The second place where we have a real gap in this state, which exists in other parts of the country too, is that extended care facilities. So what's called skilled nursing facilities. So patients who leave hospitals, who need care when they leave the hospitals, unfortunately, the vast majority of them in this state will not allow patients to enter if they are being treated with buprenorphine. So we often we miss opportunities to initiate buprenorphine for patients who would benefit from it while they're in the care, while they're in the acute care hospital, and Worse than that, we sometimes take people who are stable on medication like buprenorphine and take them off of it and put them back onto full mu agonist opioids, such as oxycodone, because that's the only way we can get them to a skilled nursing facility. So we destabilize patients sometimes to get them to a skilled nursing facility. So these are two areas that really need the attention of our elected officials to see what a tremendous problem this is, but not only that, what a tremendous opportunity is to improve care and help patients maintain continuity of care.